complications. I'm not really getting into the surgical part of it because it's such a broad topic. We'd be here for a long time. So let's get started. What is heart failure? Heart failure is a chronic progressive condition in which the heart's muscle is unable to pump enough blood to meet the body's demand for blood and oxygen. This is just some statistics. The likelihood of heart failure of all adults 40 and older, 1 in 5 Americans will develop heart failure in their lifetime. Number of people, more than 6 million Americans are living with heart failure, and the number is predicted to rise by 46% over the next 15 years. And that's mostly because of, well, the aging population for one, and we're getting a little bit better at treating it, so people are living a little bit longer. Overall national costs, heart failure costs Americans more than I think $30 billion each year, and costs are expected to rise by almost $70 billion by 2030. About 80% of those costs are due to hospitalization. So, as you know, there's a big push by Medicare to keep the people out of the hospital for 30 days. And mortality, about half of people who develop heart failure die within 5 years. Symptoms and diagnostic tests. I know you already know the symptoms: dyspnea, orthopnea, fatigue and weakness, edema in the legs, ankles, and feet, rapid or irregular heartbeat, reduced exercise tolerance, persistent cough or wheezing with white or pink-tinged phlegm, increased need to urinate at night, swelling in your abdomen, ascites, very rapid weight gain from fluid retention, lack of appetite and nausea, and difficulty concentrating or decreased alertness, sudden severe shortness of breath and coughing up pink foamy mucus, and chest pain, if the heart failure is caused by heart attack. Often when you look at the medical record and the discharge summary, W10 will say the class of heart failure. There's 2 ways they classify it. This is the New York Heart Association functional classification. Class 1 would be no limitation of physical activity, does not cause undue fatigue, palpitations, dyspnea, or shortness of breath. So they don't really have any symptoms yet with Class 1. Class 2 would be a slight limitation of physical activity. They're comfortable at rest, but ordinary physical activity results in fatigue, palpitations, dyspnea, and shortness of breath. And then Class 3 is marked limitation. They're comfortable at rest, but less than ordinary activity causes fatigue, dyspnea, and palpitations. And then Class 4, which is a lot of our patients, they're unable to carry out any physical activity without discomfort, symptoms of heart failure even at rest, and if any physical activity is undertaken, discomfort increases. And this is the ACC-AHA stages of heart failure. So Class A is no objective, same thing as 1 basically. No objective evidence of cardiovascular disease, no symptoms, and no limitations. B is objective evidence of minimal cardiovascular disease, mild symptoms, comfortable at rest though. Then in Class C is where they're starting to feel it. Objective evidence of moderately severe cardiovascular disease, marked by a limitation in activity due to symptoms, even less than ordinary activity, comfortable only at rest. And then Class D is objective evidence of severe cardiovascular disease, severe limitations, and they experience symptoms even while at rest. Diagnosis of heart failure, there's a lot of tests for it. First, they would start with a medical history and physical exam, and then blood test, electrolytes, BNP, chest x-ray, electrocardiogram, echocardiogram is very important to establish the ejection fraction, which I'll talk about in a second. And stress test also to identify myocardial ischemia and also ejection fraction. CT scan and MRI used a little bit less, but coronary angiogram, that's your cardiac catheterization, would be used to look for blockages, of course, and also determine the EF, and then myocardial biopsy. This is just a review of heart structure. I don't know, it's not like you look at this all the time, so it was a review even for me to go over it, but this is just the way the blood flows through the heart. So it will come in through the superior vena cava on what is the right side, but it looks like the left side to you. Goes through the right atrium, through the tricuspid valve, and this is deoxygenated blood. And then up through the pulmonic valve, up to the pulmonary arteries. Then it gets sent to the lungs, oxygenated, comes back through the pulmonary veins, into the left atrium, and then the left ventricle, and then up through the aorta with oxygenated blood to the rest of the body. So that's normal heart function. And this is just another way of looking at it, if you like it like that. Causes of heart failure, there are a lot, and then you can see why it's so prevalent in the United States, because so many people have these diseases and disorders. So coronary artery disease is number one. Atherosclerosis, which is the hardening of the arteries caused by plaque and cholesterol, can cause less blood to reach the heart muscle. And then if blood flow becomes completely obstructive, myocardial infarction may occur. Coronary artery disease also can contribute to having high blood pressure, which may lead to heart failure also. Past MI, the denial of oxygen and nutrients damages the heart's muscle tissue, and part of it essentially dies, so that part of the tissue isn't working anymore. So the damaged heart tissue does not contract as well, which weakens the whole heart's ability to pump. Hypertension, uncontrolled hypertension. When the pressure in the blood vessels is too high, the heart must pump harder than normal to keep the blood circulating. It's going against pressure. Over time, the chambers get larger and weaker. Abnormal heart valves, when the valves don't open or close completely during each heartbeat, the heart muscle has to pump harder to keep the blood moving. Heart muscle disease, so these are all your myopathies: dilated cardiomyopathy, hypertrophic cardiomyopathy, myocarditis. Could be caused by virus, alcohol or drug use, or unknown reasons. I actually had a 34-year-old patient I saw upstairs at the hospital who drug and alcohol abuse. His EF was 10, 34.
Oh,
Crazy. And he had paracentesis and 6 liters drained. So that's a big, cocaine is a big problem with heart failure. Congenital heart defects. If the heart and its chambers don't form correctly, healthy parts of the heart have to work harder to compensate. Severe lung disease, this is a lot of our patients too, the COPD patients. When lungs don't work properly, the heart has to work harder to get available oxygen to the rest of the body. Diabetes, people with diabetes tend to develop hypertension and atherosclerosis from elevated lipid levels in the blood. And obesity can cause the heart to work much harder, can cause also sleep apnea, which can cause cardiomyopathy. And then sleep apnea is a potentially life-threatening disorder. Sleep apnea is also a risk factor for medical problems like hypertension, heart failure, diabetes, and stroke. Other conditions that can temporarily impair the heart's ability to keep up with the body's demand, but not necessarily a structural problem. Severe anemia. The heart can become overtaxed by trying to move a small amount of blood at a fast rate. Hyperthyroidism, which could be corrected, but this condition can cause the body to work at a faster pace and the heart can be overworked by trying to keep up. Arrhythmias, when the heart beats too fast, too slow, or irregularly, it may not be able to pump enough blood to meet all the body's needs. So that happens a lot with our AFib patients. If you go and see a patient's legs are starting to swell out of nowhere, and you check their pulse and it's like 120 irregular, their heart failure might be caused by AFib. Pathophysiology. So this can get really confusing, but try to break it down. So this is like the basic thing. So with heart failure, neurohormonal pathways are activated to increase circulating blood volume. So it's like a body's way of compensating for what's happening. So the weakened heart tries to compensate by initially getting larger, pumping faster, and increasing muscle mass. It also may narrow the blood vessels in attempt to keep blood pressure up and divert blood away from other organs like the kidneys, liver, and brain. So at first this compensatory mechanism works for a little while. And this is like the more technical part of it. So chronic heart failure is associated with neurohormonal activation and alterations in autonomic control. The sympathetic nervous system is activated in early heart failure as an early compensatory mechanism, which provides inotropic support to keep that blood pressure up and maintain cardiac output. Chronic sympathetic activation, however, causes further deterioration in cardiac function, so it's actually damaging itself by doing this. Stimulation of the renin-angiotensin-aldosterone system, which is very confusing, but it results in vasoconstriction. It results in sodium and water retention and release of aldosterone. And then natriuretic peptides are released in response to myocardial fiber stretch. So that's when we measure a BNP level, that's what we're measuring, the stretch of the myocardium. And then catecholamine release aggravates ischemia, causes dysrhythmias, and promotes cardiac remodeling. Antidiuretic hormone concentrations are increased in severe chronic heart failure. High concentrations of the hormone are particularly common in patients receiving diuretic treatment, and this may contribute to the developing of hyponatremia. Endothelin is secreted by the vascular endothelial cells and is a potent vasoconstrictor that has vasoconstrictor effects on the renal vasculature, promoting retention of sodium. So basically, the neurohormone pathways are initially beneficial as compensatory mechanisms, but eventually these mechanisms no longer work, and the heart actually starts to remodel itself. The left ventricle can get larger, stretched out, boggy, causing left ventricular dilation, hypertrophy, and can cause ischemia. The body can no longer keep up with the workload, and now the patient starts to experience symptoms. So left-sided heart failure is usually where the heart failure starts. You could have an infarct in the right side, but usually it's the left side that is affected first. So the left ventricle supplies most of the heart's pumping power. So it's larger than other chambers and essential for normal function. In left-sided or left ventricular heart failure, the left side of the heart must work harder to pump the same amount of blood. There are two types of left-sided heart failure, and the first one is probably more common, heart failure with a reduced ejection fraction, which was formerly known as just systolic failure, and then heart failure with a preserved ejection fraction, or called diastolic heart failure or diastolic dysfunction. Just quick about EF, it's a measurement of the amount of blood that the left ventricle pumps out with each contraction. It's measured by echocardiogram, cardiac cath, MRI, CT scan, or nuclear scan. So a normal EF is about 50 to 70%. It kind of depends on what data you're looking at, but it's around there. Person could have a normal EF though with diastolic failure, but they still have heart failure. An EF of 41 to 49% is considered borderline. Doesn't always indicate that a person is developing heart failure, but it may, another typo, may indicate previous damage from an MI. An EF under 40 may be evidence of heart failure or cardiomyopathy, and then over 75 is also abnormal. It could be caused by hypertrophic cardiomyopathy. This is just what systolic and diastolic heart failure look like. So with systolic, we have these stretched and thin chambers, and the heart can't pump well. It can't eject enough blood out, and everything gets backed up. And then with the diastolic heart failure, the heart can't fill properly, so it's a filling problem. So you're getting less blood into the heart initially. This is systolic heart failure with a reduced ejection fraction. Left ventricle loses its ability to contract effectively. The heart can't pump with enough force to push in the blood into circulation. So less oxygen-rich blood is pumped out of the body. Or pumped to the body. This is contractile dysfunction. The left ventricle is unable to effectively eject blood into the higher pressure aorta. And with progression, LV wall thins and LV chamber dilates, so you have this big, huge left ventricle. An EF is generally less than 40%, and the most common cause is ischemic disease. Diastolic failure, diastolic dysfunction, heart failure with preserved EF. These are your over 40 EFs, or usually over 50 EFs actually. The left ventricle loses its ability to relax normally because the heart has become stiff. So you can see it's got these thick walls, even the septum is thick. The heart can't properly fill with blood during the resting period with each beat. So like I said, a preserved EF, we've got this small left ventricular cavity now, so not much blood is getting in there at all, so it's less preload. And there's a greater incidence in older age women, hypertension, obesity, and diabetes. And this I just added, I thought it was interesting because I find that heart failure with the diastolic heart failure patients are a little bit harder to treat sometimes because the medications are more limited. Now with systolic failure, we have Entresto and the ACE inhibitors, but they really don't work for diastolic. The doctor might try them anyway, but it's not been proven that they work very well for diastolic. So heart failure with preserved EF is a major public health problem that is rising in prevalence with the aging population and ongoing epidemics of obesity, diabetes, hypertension. Heart failure with preserved EF accounts for nearly half of all heart failure cases. Heart failure with preserved EF is associated with high morbidity and mortality. After heart failure hospitalization, the 5-year survival rate of diastolic heart failure is a dismal 35%, which is worse than most cancers. In addition, the quality of life is poor or worse than heart failure with reduced ejection fraction and is associated with physical activity levels that are similar to moderate to severe COPD patients. There are currently no effective therapies for heart failure with preserved EF. And like I said, most heart failure for reduced EF have been ineffective. Diastolic heart failure is difficult to treat and carries a poor prognosis once it presents as volume overload. Preventing heart failure with preserved EF and limiting disease progression is critical. So really you got to prevent all the risk factors, diabetes, obesity, to prevent that. Symptoms of left-sided heart failure, so this is both systolic and diastolic. They're both on the left side. Decreased cardiac output causes tachycardia, fatigue, decreased urination, angina, and restlessness. And then pulmonary congestion causes cough, especially at night, dyspnea, tachypnea, crackles, and frothy pinkish sputum. So this guy has left-sided heart failure. He has the paroxysmal nocturnal dyspnea, elevated pulmonary capillary wedge pressure, pulmonary congestion, presenting as cough, crackles, wheezes, blood-tinged sputum, tachypnea. He's got restlessness, confusion, orthopnea, tachycardia, exertional dyspnea, fatigue, and cyanosis. So, like, that's where the heart failure usually starts, in the left side, but it often causes right-sided heart failure. That's why you see patients with, you know, the edema, even though they might have systolic heart failure. So this is right-sided heart failure. This type of heart failure affects the right ventricle of the heart. The cause is usually from left-sided heart failure, so that's the main cause, but it could also be a result of damage to the right ventricle from a heart attack. When the left ventricle fails, increased fluid pressure is forced back up through the lungs, damaging the heart's right side. The now weakened right ventricle causes blood to back up into the veins, causing swelling in the body, such as the ankles, feet, and legs. Symptoms of right-sided heart failure, basically congestion of the peripheral tissues, edema, ascites, liver congestion, GI tract congestion, anorexia, weight loss, and GI distress. Another symptom that wasn't on here, but it seems to happen a lot when patients are overloaded, they go into AFib because of the congestion in the right atrium, where the SCD node is. Right-sided heart failure, fatigue, increased peripheral venous pressure, ascites, enlarged liver and spleen, may be secondary to chronic pulmonary problems, distended jugular veins, anorexia, complaints of GI distress, weight gain, and dependent edema. This is a couple of mnemonics to help you remember it if you like that kind of thing. And this is just a review. So the right-sided heart failure causes congestion of peripheral tissues, liver congestion, dependent edema, ascites, GI tract congestion. And then the left side causes the decreased cardiac output, decreased tissue perfusion, pulmonary congestion, impaired gas exchange, cyanosis, hypoxia, pulmonary edema, and then you have your orthopnea, cough, and PNP. Acute heart failure exacerbation is what we want to avoid, but I think we probably have all seen it, so I thought this is kind of accurate of what it actually looks like. The patient is in panic mode, dilated pupils, skin is pale, grayle, or cyanotic, dyspnea, orthopnea, crackles, wheezes, cough, decreased blood pressure, nausea, vomiting, ascites, edema, anxiety, falling O2 sat, confusion, JVD. They may infarct because of the stress of it on their body, fatigue. You can auscultate a S3 gallop, tachycardia, enlarged liver and spleen, decreased urine output, and weak pulse, cool, moist skin. They need to go to the hospital. They are going into shock. So we're going to treat them with medications so we avoid that. There are quite a few meds. The patients complain about being on so many meds, but you know, they all do a different thing. So first class is angiotensin converting enzyme inhibitors. So all patients with LV dysfunction should be on ACE inhibitors unless there are contraindications. So ACE inhibitors can prevent heart failure in high-risk patients who have atherosclerotic disease, hypertension, or diabetes, and/or diabetes. ACE inhibitors improve mortality, heart failure symptoms, exercise tolerance, left ventricular EF, and reduce ER visits and hospitalizations. So that's why compliance with meds are so important. The dose should be titrated up to maximum tolerated dose, side effect of ACE inhibitors is a dry cough. Serious side effects are angioedema and renal failure. So medications, the most common ones are enalapril and lisinopril that we see. And of course they can lower the blood pressure, but a lot of these patients kind of run a low blood pressure anyway, so start on a low dose and try to titrate it up as tolerated. Angiotensin receptor blockers, these are the ARBs, similar to ACE inhibitors, but work by a different mechanism. These drugs block the effect of angiotensin II, a chemical that narrows blood vessels. They help widen the blood vessels and allow blood flow to flow more easily, which lowers the blood pressure. They're generally prescribed for people who can't tolerate ACE inhibitors, and these medications are the losartan, valsartan, irbesartan. And Entresto is the one that everybody is trying to use now. Angiotensin receptor neprilysin inhibitor. It's the first in its class, and it reduces the strain on the failing heart. It contains two active components known as sacubitril and neprilysin inhibitor, and valsartan, an angiotensin receptor blocker. So Entresto is indicated to reduce the risk of cardiovascular death and hospitalization for the heart failure patient in patients with chronic heart failure, class 2 to 5, and a reduced ejection fraction. So it's really just for systolic heart failure patients. One large study showed that ARNIs reduced heart failure-related hospitalizations and prolonged life. And this is important for us. ACE inhibitors must be stopped 36 hours before ARNIs can be initiated, because the overlap of both therapies has been associated with an increased risk of angioedema and morbidity. So they have to make sure they're off of it for 3 days before they, really 3 days. Beta blocker therapy, all stable patients with reduced LVEF should receive a beta blocker unless contraindicated. Beta blockers serve as an antiarrhythmic, anti-ischemic, and they prevent that cardiac remodeling, reduction in oxygen consumption, and we start with a low dose and titrate up as tolerated. Medications include carvedilol and metoprolol succinate, metoprolol tartrate too, but usually they try to change that to the long-acting after they're out of the hospital. Loop diuretics, these are almost used in every heart failure patient. Should be used in conjunction with beta blockers and ACE inhibitors. Most heart failure patients will benefit from a loop diuretic. They reduce symptoms, but they actually don't improve survival, like the ACE inhibitors and the Entresto actually help stop that cardiac remodeling that worsens the heart failure. The diuretics just stop the fluid overload. They may need to be adjusted very frequently based on weight, symptoms, lab values, specifically BUN and creatinine. That's basically what we do in the heart failure. We don't actually use a lot of IV drugs. It's all titration of the patient's own medications, torsemide and Lasix, based on their weight and their symptoms. But after Thanksgiving, I worked yesterday, and we gave 4 people IV Lasix. Like, usually there's none. So Thanksgiving is very seldom.
Easter too?
Oh yeah.
Ham.
So these medications include furosemide, torsemide, bumetanide, and eplerenone. And actually, eplerenone should not be on there, I don't think. Epiclinic acid is one of them, though. Eplerenone is on the next one. That was a mistake. Aldosterone antagonists are the potassium-sparing diuretics. So these are usually used in addition to the loop diuretics, but they could be used on their own also. So these help get rid of the extra water without losing potassium. Sometimes you'll have a patient that their K is constantly low, and we'll try spironolactone to keep the K up, in addition to whatever else they're on, Lasix or torsemide. Shows a 30% reduction in mortality and hospitalizations with class 3 or 4 heart failure, 15% reduction in death and hospitalizations in patients with an EF of less than 40 after MI. And patients need to have their potassium levels monitored because it could raise the potassium too high. And these medications include spironolactone and eplerenone. Hydralazine in combination with nitrates. The combination of hydralazine and Iserdil is recommended to reduce mortality in African Americans with class 3 to 4 heart failure with a reduced EF on ACE inhibitors and beta blockers. And it may be used in patients with symptomatic heart failure with a low EF that have contraindications to ACE inhibitors due to hyperkalemia or renal insufficiency. So sometimes your dialysis patients or people on the borderline of dialysis are on these meds. Medications include hydralazine, isosorbide, dinitrate, and then Bidil is a combination of those. Ivabradine, I don't really see this one hardly ever. Corlinor reduces hospitalizations, I don't know why, reduces hospitalizations in patients with worsening heart failure, indicated for patients with chronic heart failure on beta blocker therapy that have a resting heart rate of 70 or higher, so they're a little on the higher side with the heart rate. It acts by reducing the heart rate via specific inhibition of pacemaker current, so it works differently than a beta blocker. And the most common side effect of this is hypertension, bradycardia, AFib, and visual disturbances. Then digoxin, we don't see it quite as much anymore. It increases myocardial contractility, may be prescribed for patients with LV dysfunction who are symptomatic with standard drug therapy. The dose may be adjusted in setting of renal failure because it's excreted by the kidneys, so they may need a every other day dose or something. And it could reduce hospitalizations but does not reduce mortality. And then I didn't do all these this time because I didn't want to keep it too long, but other interventions that are being used, and I'll give you all this info next time. It's cardiac resynchronization therapy, defibrillator therapy, LVAD, CardioMEMS, heart sensor, valvular interventions like TAVR or MitraClip, the valve surgeries, and then revascularization therapies, so cardiac cath with angioplasty. And patient education, just as a review, weigh every day, same time, first thing in the morning, after you go to the bathroom and urinate, tell them. Keep the scale in the same place, flat surface, ideally without carpet, weigh in the same amount of clothes, so the clothes that they sleep in. Write down their weight, compare it to the day before, but especially compare it to the week before. I'm still seeing like sometimes, patients come in, they've only gained 1 pound, but every day for 2 weeks, so they don't count that, but you really have to look at the week to week. Call us if you gain more than 2 pounds in a day or 5 pounds in a week. So 2 pounds is a little bit, I would say over 2 pounds is where they should really call us. Of course, if they're symptomatic too. Take your meds as directed on your medication list. Don't skip doses. If their blood pressure is a little on the low side, but they're asymptomatic, they could probably still take it. Notify us if you're having side effects. Check your med bottles every week to make sure you don't run out. That's a big one. They don't think of refilling their bottles until it's too late. And notify the pharmacy or physician if you need refills. And then the biggest challenge is limiting sodium. So encourage them to read food labels. Keep this total sodium intake to less than 2,000. So 1,500 would be great, but if we could get 2,000 or less, that's pretty good. So I usually tell them that. Don't add to the salt to your foods at the table or while cooking. Avoid processed and packaged foods, fast foods. Choose fresh foods whenever possible. Keep total fluid intake to about 2 liters or 6 to 8 cups a day. So if they're on diuretics, it doesn't mean they have to drink more. They could drink the same amount and take their diuretics, because that's the whole point of them, to get rid of the extra water in their body. Maintain physical activity as directed. Encourage them to move a little bit. I know it's hard. They might not, have much tolerance at all. Start slow. Stop exercising if they feel chest pain, dizziness, shortness of breath, or unable to finish a sentence. Don't be afraid to discuss sexual activity with your doctor. Cardiac rehab can improve symptoms, improve exercise tolerance, and improve muscle tone. Fortunately, it's only approved usually with systolic heart failure with an EF, I think less than 35. I'm hoping that changes.
Really?
Yeah. I know. Cardiac rehab can improve symptoms, improve exercise tolerance, and improve muscle tone. Know when to get help. Call 911 for chest pain that lasts more than 10 minutes and is not better with nitroglycerin if they have a prescription for it, or rest. Call 911 for severe chest pain, shortness of breath, fainting. Zone tool, I know they've been going out and being used a lot. I've been seeing them in the notes. And then keep all of their medical appointments, which is another huge challenge. Bring all the medications with them to the appointments, or a current updated medication list and a wait log. The MedRec is such a problem everywhere, so it's probably better if they just bring the bottles and the med list with them to the appointments. Write down questions beforehand. Follow through with lab draws, other ordered tests, medication changes, and update us on new changes, and ask your doctor or practitioner for written instructions. Some of the offices do send written instructions now, but not all of them, so it kind of gets lost in translation a lot of times. And that's it. The other thing we wanted to go over real quick is the stop and watch tool. We're going to have these put on, I think, Angela, the AIDS badges, or everybody?
Back to the AIDS badges.
Yeah.
We're gonna try to, get them on there. I got the stickers.
Yeah. So this is just to, we're gonna have this on the back of their badges, just because when they're with the patient, they should be part of the care, and notifying us if they notice any changes. I can't tell you how many times I've worked where the aide is the one who comes and gets me and says, your patient doesn't look good, or they're doing this or that. So it's really important for them to stay involved. So this is just a reminder of what they should be looking for. So it seems different than usual, talks or communicates less, overall needs more help, is having pain, ate less, no bowel movement in 3 days or diarrhea, drank less, weight change, agitated, nervous, tired, weak, confused, or drowsy, change in skin color or condition, help with walking, transferring, toileting more than usual. So just as a warning sign, so they can notify us to make a visit and look for a reason why they're acting like this.
And besides for the AIDS, this stop and watch kind of makes me think about like the sepsis. Sometimes your patient isn't quite themselves, but they're like, well, I didn't sleep last night, or my husband has a cold, I'm not feeling great, and you're like, well, something really going on. Are they just having an off day? Are they getting a cold? Sometimes it seems vague, and then hindsight's always 20/20. So later on, when we find out they went to the hospital, they're like, well, they were a little off, and then sometimes you go back and see a patient and they're perfectly fine. So sometimes, like, just the stop and watch, keep in mind, sometimes might be a clue that maybe something actually is going on. It's just not, a lot of little things sometimes add up to something. And then a lot of agencies and hospitals use this with their aid staff, so that they can, instead of saying she's just not herself, maybe they can say, she's not herself and she just needs more help today, she's just not really talking to me, those kind of things to help pinpoint, what it might be. And it's an Interact tool, so it's a validated and tested tool. And like I said, a lot of places are using it, so just another tool to kind of help bring everything to your attention and help involve the aides in our interdisciplinary.
It's actually simple enough that we could even use it for family members.
Totally, yeah, just, exactly, like, you know, they just, they're a little off today, you know, exactly, like, you know, maybe you can bring a couple of things.